Greetings and welcome to the MS Journal Club, a 30-year clinical MRI observational study of MS and CIS. At this time, all participants are in a listen-only mode. A question and answer session will follow the formal presentation. You may submit a question via the web at any time by using the Ask a Question feature on the left side of your screen. If anyone should require operator assistance during the conference, please press *0 on your telephone keypad. Tonight's facilitator is John Kramer. Please go ahead, sir.
Great. Thank you so much, and good evening, everyone. It's my pleasure to be the presenter for the second virtual journal club sponsored by CMSC, and I just want to first say thank you to June and the staff at CMSC for coordinating tonight's virtual journal club. I know there's a lot of moving parts behind the scenes that a lot of us don't see, but again, it's really I really appreciate all the work and hard effort you guys put into this. So the paper that I chose for this evening's webcast was recently published in Annals of Neurology earlier this year. And it's a very important paper, as the data from this paper is the longest running CIS cohort that has ever been published. But it's interesting to note that this is not the first iteration or data capture of this patient population. And so what I thought I would do is just kind of tee up the paper by first going back in time a little bit to talk about where this data capture first occurred, starting back in the mid-1980s. So again, this cohort of CIS patients comes from a single center out of the UK. And again, it is the longest running longitudinal analysis of a CIS cohort that has ever been published. Now, some of you who've been around for a while might remember the famous Brex paper, which was published in the New England Journal of Medicine in 2002, and the Fisniku et al. Paper that was published 6 years later in Brain. The current paper is a follow-on of that same patient cohort. So here's just a screenshot from the New England Journal of Medicine. Again, the Brex et al. Paper published in 2002. And so between 1984 and 1987, there were 140 patients that were recruited that were diagnosed with clinically isolated syndrome. And you'll see with the numbers are going to change in terms of the total N in the Brex paper, the Fisniku paper, and then the Chung paper, which is the main topic for this evening. They were able to go back retrospectively and analyze 71 patients in this paper from 2002. And it should be noted that at that time, none of these patients were on disease-modifying therapy. So the data suggested at the time that patients that had a clinically isolated syndrome event, they had optic neuritis, brainstem syndrome, or transverse myelitis, if they had an abnormal MRI scan of the brain at the time of the CIS, 88% of those patients by year 14 were diagnosed with clinically definite multiple sclerosis. And the median EDSS in this cohort was just a little bit over 3. Now, it's really important to take a step back and remember that clinically definite MS was an older term that we don't commonly use anymore because we now have the updated 2017 McDonald criteria. But clinically definite MS is based on the so-called Poser criteria from the early 1980s. And so in this situation, regardless of what these patients, these 44 patients, follow-up MRIs showed, it didn't matter because they had to have a second clinical event that was consistent with a demyelinating attack before they could be diagnosed with clinically definite multiple sclerosis. And now, of course, our diagnostic criteria has changed for the better, allowing for radiographic changes that if they occur, we can rule in the diagnosis much sooner rather than waiting for that second clinical event to occur. You'll see that 4 of 21 patients with normal MRI of the brain had developed clinically definite multiple sclerosis. So that's 19% of the cohort. And I actually, taking a step back personally for a minute, when I look at this type of data, I have used this data in patients who have, say, an isolated optic neuritis. They have a normal MRI scan of the brain. I think it's reassuring to patients to say, look, you don't have any obvious lesions seen on MRI at this point in time, and based on some of our older data, it's suggestive that there is a much lower risk of developing multiple sclerosis at, say, 14 years out after this initial event occurred. So the conclusions from the Breck's paper also talked about volumetric analysis on MRI. And I don't know about you guys, but I never get volumetric calculations from my neuroradiology team. But in this particular study, and I just quoted it here right out of the paper, volume on MRI after 5 years, and in particular the change in volume during the first 5 years, correlated more strongly with the EDSS score at 14 years than did measures of volume at earlier or later time points. And this was suggestive of the fact that the development of lesions in the early years with the diagnosis has an important influence on long-term disability. Now, that's an important concept to remember as we dive deeper into the current paper, the 30-year analysis of this CIS cohort. We're going to fast forward 6 years, and now we're just going to briefly, for a couple of slides, talk about the Fisniku paper, Fisniku et al. And you'll see Dr. Breck's is the second author on this particular paper, and this was, again, in Brain in 2008. So this analysis was actually able to look at 140 patients. That was the original number that the researchers had captured between 1984 and 1987. And it was interesting in this particular paper how the researchers discussed that 8 of the 140 patients that originally were diagnosed as having MS were actually misdiagnosed with MS. And you see the various diagnoses that came out of this instead: pontine arteriovenous malformation, pontine hematoma, myasthenia gravis, cerebral vascular disease, lupus, and then one patient had HIV-related complications. Remember, this is a reputable center. I think that it's important to remember there was a recent publication of Cedars-Sinai MS Center in LA showing that 18% of the patients that came to their center with a diagnosis of MS actually didn't have MS. And one of our top neurologists here in the Southeast, Dr. Harold Moses, is famous for saying that if patients have what sound like relapsing symptoms and they have no history of a brainstem syndrome, no history of optic neuritis, no history of a clinical syndrome that looks like transverse myelitis, time to start thinking possibly about a different diagnosis. And I think that's a really good gauge for making the diagnosis of relapsing MS. The history, of course, has to fit with the clinical presentation. So 140 patients were originally attempted to be captured, but again, the authors in this particular paper talked about how it was difficult for them to necessarily reach a variety of different people. Some people were overseas. A number of people chose not to continue to participate in this study. So the number is 107, but again, that's more than what we had originally with the Breck's data from 2002. And so again, these patients were evaluated at the 20-year mark on average after an initial CIS event. Only 4 of these patients were on disease-modifying therapy, and all of them had a diagnosis of relapsing MS at that time. Again, remember that this data set is somewhat old, and a number of these patients they were diagnosed with CIS and then on to MS in some cases before disease-modifying therapy was even available in Europe. So by this point in time, 67 of 107 patients had clinically definite MS, again, based on the Poser criteria. So they had to have 2 different neurological events that looked like a demyelinating attack. Again, the MRI at this point in time is not important from a diagnostic standpoint for clinically definite MS in the setting of using the Poser criteria. So that was over almost 2/3 of patients had developed clinically definite MS by 20 years. And you see the breakdown of the different types of CIS events that occurred below there. So it's interesting that the median EDSS for the optic neuritis group was 4, and the non-optic neuritis group was 5. And the p-value was not statistically significant. And I think this is an interesting data point because I still hear people will say, well, this patient was initially diagnosed with unilateral optic neuritis. They should have a favorable outcome. And I guess it's clear that at least with this particular data set, that is not necessarily the case. So of these patients that had clinically definite MS, you can see the breakdown here that the majority of these patients still had relapsing MS, but 42% had secondary progressive multiple sclerosis by this point in time. And it's also interesting to note that 40% of this cohort with MS had an EDSS score above 6. And this is interestingly in line with Dr. Brian Weinshenker's natural history data on MS from the 1980s, with his data showing that by year 15, about half of all patients needed some sort of assistive device to ambulate. So this is 39% with this study, 50% with Dr. Weinshenker's data. You see some similarities there. And similar to what we saw with the 14-year data with the Brex et al. Paper, patients that had had a normal MRI at baseline, despite having a CIS event, only 21% of these patients developed clinically definite multiple sclerosis. Whereas again, just even one lesion set patients down this path of likely developing clinically definite multiple sclerosis by year 20. 89% of patients with at least one lesion, and commonly more lesions, had developed clinically definite MS by year 20. So while again, the diagnosis of clinically definite MS is not dependent on MRI findings, it's interesting to look at the volumetric data in this paper as was looked at also in the Brex data. And what you see here, I actually highlighted this in yellow. You see that there's CIS, RMS, and SPMS, and you see the median volume of lesions, the total lesion volume in cubic centimeters below each of these clinical subtypes. And then out to the right, at 20 years, you see a strong difference, obviously, between the patients that remain CIS at year 20 versus those patients that had relapsing MS, 12.7 cubic millimeters of lesion load, and then for the secondary progressive MS cohort, it was 34.4. So you see a clear difference in total lesion volume, particularly between the patients that were diagnosed with SPMS compared to those that still had relapsing remitting multiple sclerosis. So the authors noted that the patients who developed a secondary progressive MS pattern tended to have larger baseline T2 lesion volumes and a greater increase of lesion volume, especially over the first 5 years. And this is just a direct quote right out of the paper. In summary, this long-term follow-up study demonstrates that T2 brain lesions have a moderate correlation with disability, and their predictive value appears early on in the disease. The lesion load continues to increase for at least 20 years in relapsing MS patients, and the rate of lesion growth in those who develop secondary progressive MS is higher than those who retain a relapsing remitting course. So I think there's a couple different stories here. You've got a situation where you have baseline T2 lesion volume, and then the rate of growth of lesion volume over time appears to be predictive of whether patients develop relapsing MS or develop secondary progressive multiple sclerosis. So I think, I'm going to pause here just for a minute. Maybe we can take some questions at this point in time before we go right into the Chung paper itself.
As a reminder, if you would like to ask a question, you can submit a question via the web at any time by using the Ask a Question feature on the left side of your screen. If anyone should require operator assistance, please press *0 on your telephone keypad.
Hey, John, this is Brian. Can you hear me okay?
I can.
Great. So, so far so great. You know, I think that these really lay the foundation for a lot of what we do with regard to diagnosing MS and diagnosing MS accurately. You know, one of the things that caught my curiosity when you had mentioned was the issue around misdiagnosis or inaccurate diagnosis. And I was asked this question the other day by a patient. Can I have MS if I don't have lesions in my brain or my spinal cord? And I think we all know the answer to that. But what role do you think the advances in MRI technology have played over the past several years with regard to being able to accurately identify MS lesions? You know, the original MRI scans that these folks were looking at a while ago are a lot different than the 3T high-res scanners that most of us have now.
It's a really important point, Brian, and I think that clearly with the multiple iterations of the McDonald criteria, I think that now, of course, you know, just as an example, you've got a patient with a couple, let's say they have several lesions in MS eloquent areas, one of those 5 areas that we all know, that all of course it takes is at least one new GAD enhancing or T2 lesion at 3 months after the initial scan, assuming again that they've had a CIS-like event, that then we can make the diagnosis. Whereas it could have taken years or even a decade or longer to wait for that second clinical event to be able to rule in the diagnosis. So the point you're making about the MRI technique is a good one, because I'm also going to talk about that as it relates to this paper. The original scans that were done on these patients was on a 0.5 Tesla scanner. And I'm going to show you what some of the images look like on one of the later slides. The 30-year paper we're going to talk about actually used 3T MR, which again I think is considered standard of care now for most patients. But there have been some recent studies too, Brian, showing it, and I'm sure you're aware of this, that even using 3T instead of 1.5T is going to allow you to get better visualization of lesions than you will necessarily with just 1.5 or 1 Tesla units. Anybody else? Looks like somebody put forward something online here. There was just a comment. Okay, another question just came in here. The question is, were there any studies looking at misdiagnosis using Poser criteria similar to the current studies with McDonald criteria? I have not seen that type of analysis done, but it is interesting to know, as I showed earlier, that with this Fisniku paper, in my mind, I think we always have to have a healthy suspicion about the diagnosis, unless it's an obvious slam dunk. That having some humility about this. This is a top center, and just a little over 5% of these patients were misdiagnosed as having multiple sclerosis. So, but again, no, I haven't seen any comparisons using Poser and contrasting that with the current McDonald criteria.
So there was one paper, it was in 2016 by Solomon, and it was the contemporary spectrum of MS misdiagnosis. And it was kind of an interesting article. It was published in the Green Journal, and they did look at 4 academic MS centers, and they submitted data on a group of patients, and they sort of put them in a blender, and they all did a retrospective look-see to see what the rate of misdiagnosis was, and these were again at academic MS centers, and they did account for the different diagnostic criteria. So that is one interesting paper to go back to. That was Solomon in 2016, and that was in the Green Journal. That might be something to think about for the next journal club.
Yeah, that's great. Thank you for that, Brian. That's great. Okay, let's just get right into the paper here. So forward here. So now we're going to move forward 12 years. And this is the paper that we're going to be discussing this evening. I just want to say how nice it is to see a female first author on this landmark paper, if you will. Women don't get enough credit, I think, in the world of neurology and MS specifically. So it's nice to see a female there as first author. So the authors in this paper had two main questions. And the first one was, what does the diversity look like in terms of clinical outcomes at 30 years after patients were diagnosed with a CIS? And then the other question they wanted to ask was, can we identify early on, within the first 5 years, those who will develop progressive MS or have their life shortened by MS? So again, this is the 30-year data here, and they were able to capture 120 patients in this particular analysis out of 140 from the pool of the original patients recruited from the mid-1980s. 80 out of 120 patients had clinically definite MS, so 2/3 of patients had developed MS by 30 years. Of these 80 patients, 16 had died secondary to multiple sclerosis. So that's 1 in 5, 20% of patients at 30 years had died, according to the researchers, directly from complications from the disease process. You see that there were some other additional patients that had passed away, one from a cause unknown, and there were 2 others that had a death that, 2 had deaths that were unrelated to multiple sclerosis. So remembering that of the 61 MS patients that were still alive, still over half of them had relapsing MS, and about 43% had secondary progressive MS. Only 11% of patients were treated with some form of disease-modifying therapy, and these were, again, all the brace therapy. So the what we would call we used to call in the past the platform therapies, during this time over 30 years. So again, that's no Tysabri, that's none of the oral drugs, none of the IV infusible drugs, only the interferons and the glatiramer acetate products. And this slide is a little bit small, but the key at the bottom can be a little bit confusing. Let me walk you through this here. So this is looking at 107 patients over 30 years in terms of their EDSS patterns. And what you see here, I think, is quite interesting, and probably in line with what we see not only clinically, but what has been seen in other publications too. You see this, bimodal distribution, basically, where patients that have low levels of disability tend to stay low, and then there are patients that have higher levels of disability, but you don't really see a whole lot of patients here in the middle. Now, granted, we're only talking about 107 patients, but this type of data is mirrored by a paper by Confebreau from the 1990s, showing the same type of bimodal distribution. And in that particular paper, patients, once they got to a level 4 EDSS, they were unfortunately going to be marching on to 6 and marching on to 7 eventually. So 4 is, and numbers in between, of course, are really probably just way stations in terms of eventual progression. So obviously, everyone on the line knows what we're trying to do is minimize that type of EDSS progression over time. You can see that on the far right side of the slide, the patients that did die from MS, those 16 patients, are captured there with the EDSS of 10. So I threw in this slide. This is from a single patient that was involved in this study. And to Brian's point earlier, if you can see letter A there in the upper left corner, That's what this patient's MRI scan looked like in the mid-1980s. So this is a 0.5 Tesla scanner, and the slice acquisition at that time was either 5 or 10 millimeters. And so, if you do 10 millimeter slices, you have the potential to miss a whole bunch of lesions if we're going to use 3 millimeters as a cutoff for 3 millimeters or greater for a typical demyelinating lesion. And then as you move to the right, A, B, C, D, and then EF, you start to see greater resolution of these MRIs over time. And so letter F there is a 3 Tesla magnet scanner. So this slide, and again, I apologize for the way that it's noted there in the upper right corner, but this is just the way that it was published in the paper itself. You see a similar type of distribution that you saw with the EDSS scores, in that the patients with lower levels of disability were either in the white box working full-time or had working full-time or part-time, or had retired at what they call pension age in the UK. But then on the right side, of course, as the EDSS goes up, these are patients that the vast majority of whom were not working full-time. You'll see some with the slash black and white lines down there to the right, but some of these patients were working part-time, but the numbers are very small. Which I think probably correlates with what we see every day in clinic, right? There was a recent publication out of Europe, not this data set, but looking at over 10,000 patients that showed that only about 50% of all patients who had an EDSS level of 3 or higher were working. And I think in our minds when we think about EDSS, 3 maybe doesn't sound that bad, but 54% of that particular cohort with an EDSS level of 3 were actually not employed. And again, this is, of course, patients that should be in the prime of their life, prime of their professional careers. So I'm going to take some time to go over this slide because I think this is a really interesting part of the paper. So this is table 3 from the paper. And what the researchers did is they did a multivariate regression analysis to find what the best independent early predictors of 30-year EDSS above 3.5 and below 3.5. And so if you look at the top from a predictor standpoint, the best independent predictors up to 1 year for a 30-year EDSS above 3.5 was a baseline infratentorial lesion. Okay, so if these patients had grade 1 or more infratentorial lesions versus 0, that's what they were comparing. And so the odds ratio of getting above 3.5 on EDSS at 30 years, the odds ratio is almost 17. So there's 17 times greater chance if these patients at baseline just had 1 or more infratentorial lesions. And then you can see it highly statistically significant here at 0.009. And then if you look at the 1-year deep white matter lesion count, so a lot of these patients after initial diagnosis of CIS would have repeat MRI done at 1 year. And so this would suggest radiographic lesion growth over time during that 1-year period after the original diagnosis of CIS. And that odds ratio was almost 7. So again, going back to this theme from the Brex and the Fisniku data that new lesion formation early, even just 1 or more white matter lesions, deep white matter lesions, tended to push patients down this road of having an EDSS of greater than 3.5, also statistically significant. If you look at, they also did model predicted probabilities, and that's that's a third line down, if you will. So if you had none of those, if you didn't have a baseline infratentorial lesion, and if you didn't have new development of a deep white matter lesion at 1 year, your chance of going on to have an EDSS at year 30 above 3.5 was only 13%. And you can kind of play with the dials here, so to speak. As you go to the right, if you look at patients that had one or more baseline infratentorial lesions on the far right side of the slide, and one or more deep white matter lesions 1 year after the diagnosis of CIS, that patient type had a 94% chance of having an EDSS level of 3.5 or higher by year 30. And so you can, of course, flip this around too, right? So you can look at model predicted probabilities just look at the converse. So those patients that had no baseline infratentorial lesions, had no deep white matter lesions formation at 1 year, 87% chance of not going on, 87% chance of being at 3.5 or lower on EDSS, and only 6% of that cohort with no lesions in those areas would go on to develop more of a progressive MS, right, above 3.5 EDSS at 30 years. And so that's at up to 1 year. So that's really early after a CIS diagnosis. So then if you look at predictions up to 5 years, what did that look like? And so if you look at baseline infratentorial lesion count, again, same concept here, 1 or more versus 0, odds ratio 8, so 8 times greater chance just with that particular lesion location. And then they looked at the 5-year deep white matter lesion count, so greater than 5 versus 5 or less. And so what you can see here too is that these, again, you can look at these combinations here. Model prediction probabilities for a 30-year EDSS at the 5-year mark was only 18% if patients had 5 or fewer deep white matter lesions and no baseline infratentorial lesions. And then as you go to the far right, those patients that had 1 or more baseline infratentorial lesions and more than 5 deep white matter lesions, 90% of those patients would go on to develop a 30-year EDSS score of above 3.5. I will also point out quickly that it's interesting that the authors admittedly called this cutoff of 3.5 somewhat arbitrary, in that they wanted to use 3.5 because once you hit 4, now we're talking about impairment of ambulation as it relates to EDSS. So they, in the researchers' minds, they're like, well, 3.5 is considered milder disease. But again, as we discussed, there's plenty of people that are at 3 or 3.5 that either aren't employed or have significant cognitive dysfunction, which of course isn't captured very well at all on EDSS, that might still have significant cognitive disability.
Hey, John.
Yeah.
Yeah, it's Brian. We had a question come in online that I thought was a good one pertaining to this slide. So maybe we could address it. I think we're going to talk about it a little bit later on also, but it really has to deal with the importance of infratentorial lesions. And do we think that that's going to help shape our decision making regarding starting a disease-modifying therapy, and if so, how aggressive we're going to be with that individual? You know, it's kind of like the old real estate analogy. It's all about location, location, location. And so if there's an infratentorial lesion that we know is in a prime real estate area, you know, are we going to be more likely to be a little bit more aggressive? You know, someone who's 25 and otherwise healthy, that has an infratentorial lesion, that's one thing. But you know, if somebody is older or if they have that lesion, we can't make it go away. How are they going to be when they're 45 or 55 or 65? Do you have any ideas? How important that might be in shaping what we're going to do and how we approach the patient?
Yeah, I know it's a really important point, Brian. I think that I use your location analogy with a patient today. So it's really pertinent though, right? And when I talk to patients, I think about the brain like a funnel. And certainly the brain stem would fall near the bottom where the water's coming out. Obviously, the lesions there, of course, certainly can cause significant neurological symptoms, even devastating neurological symptoms. So that's one thing that I think is really compelling about this data. That regardless of what the patient may look like after an initial brainstem event, maybe they have full recovery from a double vision from an INO or vertigo. That's great, but the problem is it looks like a lot of these patients are set up for failure right out of the gate. And yes, I mean, in my mind, I will use this type of data point to explain to patients, perhaps those who are more reticent to going on a therapy that might be a higher efficacious therapy, for instance. They listen, or no therapy at all, right? Like if we do nothing, here's your probability of having significant disability when you're 55, to your 25-year-old patient analogy earlier. I think it's pretty powerful, actually, because, again, there's no other data set out there that's going to give us this type of information after an initial CIS. And furthermore, to your point about location, MRI of the cervical cord was captured in somewhat of a haphazard way. So there's no cord imaging that is a part of this particular study or paper. They just didn't have enough time points with cervical cord MRI to bring into the picture here. But again, if you think about the infratentorial compartment and its proximity to the cord, I mean, I wonder if it can be a proxy for spinal cord lesions. We don't know. We're not going to know because we just don't have that data here.
Yeah, that's a great point. It's interesting how many times I'll see a patient who's being referred on to us as a tertiary center. They've been diagnosed with MS, correctly so, but for whatever reason, they're being referred on to us, and they may have a few years worth of yearly MRI scans, but they were always MRI scans of the brain, and no one really looked at the cord. And I think that does the patient a disservice if you're not looking at the cord, certainly initially, but when adjusting a therapy or if they're having new symptoms, I think the spinal cord kind of gets left out sometimes.
Absolutely. There's a question that came in here, Brian, in the boxes. Does lesion location suggest a different pathophysiology versus perivascular, for example? I think the short answer is that it does. I mean, if you look at the updated McDonald criteria from 2017, now we have gray matter lesions that are part of that diagnostic process. So the problem is that only about 4% of those lesions are seen on conventional MRI, and I commonly squint at my computer screen trying to see if it's juxtacortical or actually cortical. But for instance, cortical lesions have a different pathophysiological pattern in that there appears to be less demyelination and more axonal transection there than, say, lesions that are in the deep white matter. So yeah, I think lesion location does matter from a pathophysiological process, at least if we're thinking about a cortical or gray matter lesion versus a white matter lesion.
Yeah, I totally agree with you. And even though we are getting more and more advanced with our MRI techniques and field strengths and so forth, I think that our limitation really is being able to quantify and qualify cortical involvement. I mean, what we have now is atrophy, and once you have atrophy, then it's done, right? The ship has sailed. So there's nothing you can do or act on that. But if we're able to catch that earlier on, then I think that would be certainly meaningful use upon which to act.
Yeah, absolutely. I'm going to go on to the next slide here. This is from Table 4. There's just a couple more slides after this one. They're just conclusion slides, and then we can open it up. So this particular table, Table 4, looked also at these independent early predictive factors of a 30-year SPMS status. Okay, so we're not just talking about 3.5 lower than 3.5 or greater than 3.5. And again, you see a similar type picture here, right? If you again have baseline infiltratorial lesion of 1 or more versus 0, your odds ratio of going on to have developed SPMS by 30 years is 26 times greater just by having 1 or more infiltratorial lesions and a CIS. And if you have a 1-year follow-on MRI and have a deep white matter lesion that shows up all by itself, just that change alone, almost 9 times greater risk of having SPMS develop at some point in time over the next 30 years. And if you put these together, 94% chance if you have that type of MRI pattern that changes. So again, a neurologically eloquent area like Brian was describing earlier, and change over the first year, even just a deep white matter lesion. And the authors were quite clear too that these were not periventricular lesions, that the deep white matter lesions were actually distal to the periventricular white matter. So that could be a relatively maybe insignificant lesion location for lots of us if we see one new small deep white matter lesion, say on MRI at any given time. But and of course the inverse is true too. So if you don't have those lesions in those locations, then you have a 7% chance of having developed SPMS by 30 years. And then again, looking at the first 5 years of activity overall, you see here this 5-year deep white matter lesion count greater than 5 puts you at an odds ratio of 5 times higher of developing SPMS over the course of 30 years compared to having 5 or fewer deep white matter lesions. And this next point I thought was really interesting. So EDSS score change from time of diagnosis to 5 years. And again, so we've been talking a lot about the MRI activity at year 1 and at year 5 after a CIS, but this really, I think, helps us understand what is going on clinically from a disability standpoint. And they looked at greater than or equal to 2 for EDSS over 5 years since time of diagnosis of CIS versus less than 2. And so if at 5 years after the time of diagnosis, your EDSS is 2 or higher, the odds ratio of developing secondary progressive MS over the course of 30 years is 31 times higher than if you were less than 2. I happen to do, as a rater, I do EDSS from time to time in clinical trials, and you can get to 2 in a heartbeat, and it's not that hard to get to an EDSS level of 2. So again, I think this hinges on this concept of the importance of early clinical and radiographic activity within the first 5 years. So if you've had 5 or more deep white matter lesions and your EDSS was 2 or greater at 5 years, you have a 96% chance based on this data, again, untreated, vast majority untreated, 96% chance that patient will develop secondary progressive MS by year 30. And it's important to note that the annual risk for a relapsing MS patient to convert to secondary progressive MS is about 2% per year. So, people of course always ask, well, when am I going to be in a wheelchair? When am I going to be significantly disabled? And of course, we can't predict these things, but it's important to remember that it's over the course of 30 years, the development of SPMS is always a potential risk, obviously even more so in this untreated population. So, conclusions, this paper represents the longest running cohort of untreated CIS patients. And given the current treatment landscape and, of course, obvious ethical issues, we're likely not going to see such a study cohort again. And so over the 30 years, CIS patients, according to these authors in the study, fell into 3 buckets. Little or no disability, per their definition, being EDSS less than 3.5, significant disability, greater than 3.5, and then death due to MS. And when I was thinking about presenting this paper, I was thinking, gosh, I mean, it seems like a lot of the patient population that I see as well, patients that do really poorly, some patients that just accrue disability over time, and then you have these patients that, for whatever reason, just do well over time, perhaps even on no therapeutic drug at all. I had a patient in clinic yesterday who's 41, owns her own farm. She's 61 years old. She's got a head full of lesions. She's not on drug, hasn't had an MRI done since 2015, doesn't want to get one. And other than a mild right facial, she is functioning as normally as any other 61-year-old female. So it's always interesting to see how patients do, particularly those that have not been treated over long periods of time. The other conclusion slide here. So it's interesting to know that 30-year outcomes were not independently associated with things that I think a lot of times we may hinge on and even talk with patients about. Say, age at onset, male versus female gender, baseline EDSS score, and CIS type also did not seem to be independently associated with a CIS, SPMS, or RMS outcome at 30 years. What was more important than MRI lesion counts actually were more important predictors than the EDSS scores. And lesion location was more important than lesion number, although lesion number was also statistically significant. So, of course, more lesions tended to portend a more aggressive or poor outcome. But again, as we talked about, those early baseline infratentorial lesions and then change at 1 year, particularly deep white matter lesions, at least for this cohort, seem to predict the risk of going above 3.5 or staying below 3.5 on EDSS, which is what we just talked about here. So again, just reiterating, patients with baseline infratentorial lesions and a deep white matter lesion or lesions by 1 year into the CIS diagnosis had a 94% chance of having secondary progressive MS at year 30, by year 30. Patients with one or more infratentorial lesions by 1 year were 5 times more likely to die from MS over this 30-year time period. And then conversely, the absence of both baseline infratentorial and 1 year deep white matter lesions gave an 87% probability of an EDSS less than 3.5 at 30 years. Now, finally, this is just the last slide talking about the study limitations that the authors readily talk about for a couple paragraphs. This is a single center population. I never saw anything about race that was talked about in all 3 of these papers. So it's unclear as to what the ethnicity is of this particular cohort. They also talked about how the so-called invisible symptoms or PROs also were not captured as part of this data set. And Brian had raised this topic earlier, the variability in MRI image quality, and I showed you that one slide about how grainy or hazy this was back in the mid-'80s. No gadolinium analyses were done with these patients. So also from a T1 to look for black holes, they only acquired pre-contrast T1 sequences in years 14 and 20 respectively. As we said earlier, the spinal cord imaging was not routinely obtained. And cognitive assessments were done. They actually did BICAMs in the 30-year study. And what they found was that there was no significant difference between the CIS patients and the RMS patients that had an EDSS of less than 3.5. But the patients that had a 3.5 or higher EDSS were found to be statistically significantly worse on BICAMs compared to those patients with CIS. Then finally, the odds, the confidence intervals with the odds ratios were somewhat wide, but however, they were still highly statistically significant. So that's the last formal slide. I think we were going to, I just want to say real quickly, I want to say thank you for the educational grants that we received to put on this program. So Celgene Corporation, EMD Serono, Genentech, and Mallinckrodt Pharmaceuticals were all key contributors to this program. So thank you for that. Hector, can we just open the line up now and just kind of have a general discussion if people want to bring up points or comments or questions?
Yes, absolutely. Lines are now open. If you'd like to address any questions, you may do so now.
And hey, John, this is Brian. I just saw another comment come up. we might have touched on this with that last conclusion slide, but can we maybe have a little bit of a discussion around the confounding variables, as to maybe why some didn't convert to MS, and why some might have had a different course as far as severity. There are lots of variables that I say that we just don't know about now. I tell my patients that I don't like to lump them into specific buckets as to having relapsing MS or primary progressive versus secondary progressive, just because everybody's MS is different. But maybe we can have a little bit more discussion around the variables that are out there.
In terms of risk of going on to develop MS as it relates to this particular paper, or you're just talking about in general, Brian?
Yeah. That, and I guess we could talk about it in general as well. I think the fact that we have so many current disease-modifying therapies with differing mechanisms of action, and some work for some patients and don't for another, I think that invariably leads us to believe that this is very phenotypically diverse disease state, and not all MS is the same.
Yeah, it's so interesting. I mean, again, I hearken back to this patient that I saw that had the disease for 41 years, and looking at her brain images, I mean, her lesion load, her volumetric load, even though, again, I don't get a specific number on that, would definitely be in line with somebody who had more of a secondary progressive MS phenotype. And, why is that? One thing, going back to what somebody had put in the chat box earlier, it's interesting that the lesion itself, a T2 lesion itself, there's variability as to what's going on in that lesion. There was one study done showing that 58% of T2 lesions actually have significant remyelination going on inside of them. So just because it looks scarred and white and maybe ugly on MR, that does not necessarily mean that there isn't recovery or remyelination or healing going on in that particular lesion.
Yeah, I think that's right. I mean, if you look at some of the MRI studies that were done at NIH, where they had serial MRI scans very frequently in the same patient, and I'm always amazed at that graphic that's sort of time-lapsed, and you can sort of see these lesions kind of sort of flare up and come down and flare up and come down. And,
with no symptoms.
That, and, later on, folks will have a significant number of T1 hypo-intensities, but not necessarily all of those T2 hyperintense lesions would correlate to a T1 hypo-intense lesion. Right,
and that's certainly a drawback that they didn't capture the T1 black holes. There was a paper done recently showing that there was a much greater likelihood of not being employed if patients had a significant number of T1 hypointensities on MR, because of course that's cored out tissue that's not coming back. So it would have been nice to see that. There's also there's a paper that was done by Dr. Stenkowitz out in Boston that really, if you look at some of his references, kind of blows up this idea of the traditional factors that we think about in terms of people who are going to be at much higher risk of having a bad outcome. And so that would be it. It's actually available on the subjournal Neurology, Neuroimmunology, and Neuroinflammation. And that's actually open access for everybody. So that's just a subjournal of the Green Journal that everyone can read.
Then there was another question about, and honestly, I'm flipping through the paper trying to see if I could locate this myself. For those folks who died, do we know if they were on a disease-modifying therapy or not? And I'm trying to look through real quick.
It's interesting, yeah. So, and the other important point that they made was that 11% of patients, well, let me back up. So no patients were on disease-modifying therapy with the Brex data. 4 patients were on some, again, interferon glutiramer in the Fisniku data, and then 11% of patients in the Chung data on the current paper we're talking about were on a disease-modifying therapy at some time, is the way that it was written. So they didn't say anything about at time of death were those patients on disease-modifying therapy. But if you go back to the original pivotal beta-seron trial, they went back and they did the same type of data capture. They had to go back and try and find these patients 20 years later, and it was interesting to find that of the patients treated with beta-seron versus placebo, that the death rate was actually lower for early interferon exposure in that particular trial. So take that for what it's worth.
Yeah, I think one of the confounding variables moving forward to try to do some of these studies would be the availability of records review. Given the fact that there are multiple EHR systems these days, and with the ability to sort of data mine, where in some regards we're able to do a lot of data mining, I think it's going to be a little bit more difficult to do things like that, given how locked down some databases are, and the fact that they're not really, 1, user-friendly, or 2, interoperable. So I think trying to do some data mining with the existing EHR systems that we have will be difficult to track who is on what DMT for how long and when.
Right. I do want to address one quick question here at near the bottom here. Can you address the possible confounds, e.g. 1/3 of patients did not convert to MS, and all EDSS-10 may not have died due to MS. So if you look at the table, let me find that here. So this EDSS Patterns, the 107 patients, you'll see it's a little, I apologize again for the small print, but on the far right side, that 10 bar, that's 10 EDSS, so death due to MS. So that's 16. There was 1 patient that died from unknown causes, and then 2 died of this cohort unrelated. They were able to determine that the death was not due to multiple sclerosis. So, and again, it's one of these things where, to me, it seems quite clear that early disability matters in the first 5 years. Early lesion activity matters a lot in the first 5 years, and really sets these patients up for having problems at year 10, year 20, year 30, whenever that SPMS starts to kick in. And again, I think only further emphasizing the importance of early disease-modifying therapy, and perhaps, Brian, to your point, for patients that maybe fit this type of phenotype and radiographic pattern, maybe those are the patients that need higher efficacy therapy, whatever that means to people on the phone, but they might need a higher efficacy therapy early, rather than perhaps a lower efficacy disease-modifying therapy.
Yeah, agreed. So I know that we're at the top of the hour, so I want to be respectful and mindful of everyone's time. I think that we've had some great questions, and really want to thank you for spearheading and leading this discussion. So if anybody else had any additional comments or questions, if they wanted to type furiously into the question box, we could address those.
And just a quick final announcement too, while we're waiting for any other possible questions, there's going to be email instructions to claim credit for this from CMSC tomorrow.
And as a reminder, all lines are live, so if you have any questions, you can direct them now to the doctors or the presenters. Apologize.
I will address one quick thing. This new drug, Mylaviz, used with PET scans, will have a role in treatment decisions. This is a a really interesting compound that was developed at Cleveland Clinic, and it will be interesting to see that. First of all, I mean, is it going to be FDA approved? It seems likely that it will, but will the use of PET scan with this MyeloViz give us a better understanding of a patient who perhaps might be at greater risk or have greater levels of demyelination and axonal transection early in the disease process that we can't see with our current conventional MRI technique? So I am really excited about this possibility and its potential approval in the near future. So great. Thank you, everyone, for participating this evening. I really enjoyed presenting this, and I look forward to our next presentation, which I think will be within the next month or so. There'll be an email going out about that. Thank you all.
Thanks, John.
This concludes today's conference. You may disconnect your lines at this time. Thank you for your participation.